Hi, I'm James Myers. I'm a family physician and a clinical informaticist. You can find me on Substack as the EMR Functional Design Guy, and this is another video in the EMR design series. This one is on assessment and plan, specifically problem selection and coding. So here's my depiction of today's ultra-modern EMRs. And this is a search box where we would add a new diagnosis. I would start by typing part of a diagnosis like diabetes, and then I would get a list of matches. But the order in which these diagnoses appear is often unpredictable, the formatting inconsistent, and they're not in any sort of hierarchy made for exploring related diagnoses in a logical way. And we end up with problem lists that look like this. Look how dense this is. There's a lot of duplication. Some of the problem names are 10 or 15 words long. It's sorted by name, and yet back pain's up here, and it's also down here. Diabetes is down here, and it's also up here. And I could try to sort it in a different way, say by date, but it would sort it by the date the problems were added to the system. So the viral respiratory infection, the cold the patient had last month, is more important than diabetes, just because diabetes was first diagnosed a year ago. If you're a patient, this is what your doctor is looking at when they're trying to treat you. It doesn't make any sense. How can we do this completely differently? Introducing or reintroducing Oriole, our fast, clean, functional EMR, or rather a fantasy of an EMR. It doesn't exist. It's just a graphical tool that I'm using to demonstrate EMR ideas and principles. In Oriole, we would start searching a problem in the same fashion by typing part of the word diabetes. Our match list would look quite different, starting with categorical diagnoses that can be further refined. And in the last video, we showed how in just a few clicks, we could explore complications and subcomplications, and in just 4 or 5 clicks we could actually add a categorical diagnosis of diabetes and the specific diagnoses of nephropathy and polyneuropathy in a way that'll look beautiful on the problem list and be easy to bill later. So let's take a look at Oriole's problem list. This is the problem list. It's short, clean, the names are concise, and believe it or not, this contains all the same problems as this. Only in Oriole, you'll see that many of the problems are grouped under categories like back pain and type 2 diabetes. We can sort it various ways as well. You notice at the top, there's a checkbox that says categorical first, which will bring categorical diagnoses to the top. And then I can sort by date last addressed instead of date the problem was added. And this will show me which problems are most likely that need to be dealt with today. Now I can click to expand a categorical diagnosis like type 2 diabetes, and I'll see the specific complications underneath it where they belong. If I expand back pain, I'll see the various diagnoses that have been used to treat back pain in the past. And look here, here's lumbar back pain and here's lumbosacral with radiculopathy. That's a much more specific, a better diagnosis to use for billing. And so that problem list is actually inviting me to clean it because it's obvious I can just remove this one and use this one instead. In contrast, does this problem list invite the reader to see similar diagnoses and determine which one is more specific and remove the other one? I think the answer is no. Okay, so let's see how this problem list would look when we're actually assessing problems in an office visit. It looks just the same. It's on the left, but now there's checkboxes for selecting the problems we're going to assess, and you can see the assessment and plan window on the right. I'm going to start by selecting type 2 diabetes, the general category, and it appears as problem number 1 over here. In the notes section, I can type in my assessment and plan from today. And in this RX section, this is orders. I would hit the plus sign to bring up an orders interface to enter all the orders. For today, I'm just going to click this and have the orders just appear. There's a prescription renewal and a couple of labs ordered. And now let's go down to this coding section. You can see that type 2 diabetes without complications is selected here. That's automatic because I selected type 2 diabetes as a category here. But you notice that this is in red and there's an icon, a warning at the end of the line with an S on it. And if I hover over it, it says, consider choosing a more specific diagnosis. S is for specific. That's because once a patient has complications like nephropathy and polyneuropathy, I should be coding for those if at all possible. If we look at my plan, I did mention maintaining blood pressure and seeing a renal specialist, so I'm definitely thinking about kidney function. So I'm going to go ahead and click type 2 diabetes with nephropathy. You notice that when I check it off here, it was automatically checked off up here. Now, type 2 diabetes with polyneuropathy is also red, but the warning icon on that is a calendar. If I hover, it says diagnosis not assessed recently. That's because if this diagnosis has not been passed to the payer, the insurance companies, in the past year, they will often consider that the patient no longer has this problem. They're cured, which means that they'll lower the risk index on that patient. If it's a widespread practice in my clinic, that will affect the risk indices for the whole organization. And when we go to negotiate our value-based contracts, we'll get paid less money per month for our patients. Much more on that in the article already published called The Coding for Fallacy, which you can find on Substack. So I'm going to go ahead and check off type 2 diabetes with polyneuropathy. And in my plan up here, I'm just going to add a quick line about continue gabapentin for neuropathy. That way I show that I'm thinking about that today. Notice that long-term use of insulin is also checked off in this coding section. That's because Oriel detected that the patient is taking insulin, and it knows that we should add that to our code for today because we might get reimbursed more for that. Okay, let's do a slightly different example. Let's imagine that I want to diagnose diabetic nephropathy separately, like this. Now diagnosis number 1 is type 2 diabetes with nephropathy. And then I could separately assess diabetic polyneuropathy. Now diagnosis number 2 is type 2 diabetes with polyneuropathy. It collapsed diagnosis number 1. I'm going to expand it again just so we can see them both. Now imagine I were to go over here and check the category. What do you think would happen? Now it automatically collapsed them both into a single diagnosis with multiple checkboxes for the coding, just like before. But I'm going to uncheck this and split it back into 2. And I'm going to expand this top one again so we can see them both at once. Now I'm going to go ahead and put in my assessment and plan under the notes for diabetes with nephropathy. And I'm going to add my orders like I did before. Now I'm going to go and add a note for polyneuropathy, that gabapentin note. And I'm also going to put in an order, like a referral to a neurologist. That's probably the reason I would split these two up like this in the first place, is that the neurology referral should have an exact diagnosis associated with it, not a general diagnosis. If I were to now click on this expanded view and look at the history of assessments for diabetic nephropathy, I would see this history there, but not this. If I looked at diabetic polyneuropathy, I would see this assessment there, but not this. But if I were to look under type 2 diabetes and look at the history of all the plans in the past, I would see them all for all the different complications, all sorted in time order, which largely addresses the long-standing problem that billing and coding regulations make us choose multiple diagnoses for the same problem, and we end up splitting up our plan and our orders and fracturing the story in multiple places so that it's very hard to put together again. Okay, let's look at one more problem, laceration. Let's imagine we're assessing that today. I'm going to go ahead and put in my plan. I'm not going to add any particular orders. And if you look down here in the coding section, you'll see there are 3 sub-diagnoses depending on whether this is an initial or a follow-up encounter, etc. This is all mandated by the way ICD-10 is set up. And as you can see, it's set up this way for some diagnoses, like a finger injury, but not for others, like diabetes. Nevertheless, Oriel tries to guess that because it hasn't seen this problem assessed before in this system, that this is the initial encounter. But you notice that this line is in yellow, and there's an E warning at the end. If I hover, it says review episode of care. This is an episode of care warning. And sure enough, if we look up here at the notes, this laceration was treated 6 days ago in the emergency room. Sutures were put in place. It was definitively treated already in another setting. Therefore, this is actually a subsequent encounter, and I'm going to click that off. So hopefully that gives you an idea how this will work. That's it for this video. What else do we have as far as assessment and plan? In the next video, we're going to talk about diagnosis history and encounter history, which are super important. We're going to talk about using a problem overview. This is a feature that is either missing or crippled in just about every EMR, but could be tremendously powerful and a great place for AI to enhance our experience. We're going to look at the visit transitions for longitudinal care that are empowered by these features. This could be a game changer in primary care if it's done right. We're going to talk about intelligent encounter billing, CPT codes, and a whole lot more. So that's it for now.